Thank you, Dr. Richardson and the panel and the chairs for the opportunity to present today. Very interesting topic, but a very difficult problem to manage. I've got nothing to disclose. This slide you've just seen, as have you seen the definition that gastroparesis is defined as a symptomatic delay in gastric emptying in the absence of mechanical obstruction. That sounds very easy, but looking at that picture on the left, all those changes that happen with gastroparesis, both causing and as an effect of gastroparesis, makes this a very difficult problem. And clearly, with such a complex problem, there's not going to be one single fix for it. There's a significant overlap with functional dyspepsia. Major differences are the significant nausea and vomiting, which I would postulate as being the two cardinal symptoms. There's probably some work coming out in the near future as an international consensus saying that if nausea and vomiting are not present, then gastroparesis is not present, irrespective of gastric emptying studies. And that's important because of the overlap. Certainly a functional dyspepsia is not a surgical disease. A lot of this talk is based on, as was referred to, the AGA clinical practice update of a couple of years ago. The first point they make quite rightly is to verify the methodology of the gastric emptying studies. We know that gastric emptying studies are not associated necessarily with the severity of symptoms. We know that some people with bad gastric emptying can have minor symptoms and vice versa. We know that gastric emptying studies are not always reproducible and they change with time, so the diagnosis shouldn't be made on a single study. And we know that the protocols for doing them vary widely. There's been published standards of how to do them with documentation of blood glucose levels and the cessation of opiates, other medications, as well as other technical aspects. And at least in my area of the world, these are very rarely reported by the reporting nuclear medicine studies, and I know that's the case in many other places. So do look at the methodology, look for the 4-hour test, the non-extrapolated data. The most important thing is to identify the symptoms the patient is presenting with. If they're presenting with nausea and vomiting, you don't need to treat the gastric emptying necessarily, you need to treat the nausea and vomiting. If you start treating things that the patient doesn't have, you're going to keep these patients on your books for a very long time, and it's going to be a very difficult relationship. You have to be very, very cautious and stop the opioids. The opioids cause a lot of problems, and they certainly make just about every treatment we offer less effective. Stop opiates. Reduce the fat diet, dietary modification to improve gastric emptying. All those drugs we just spoke about are very important. Cognitive behavioural therapy is very important, as is other psychological medicine adjuncts. Enteral feeding, both to decrease symptoms but also to improve nutrition, is important. Gastroparesis is a chronic disease. It's associated with a decreased quality of life, loss of productivity, significant healthcare costs. The symptoms are persistent, and it does not matter which treatment we offer these patients. This is a chronic disease which often relapses and recurs in the majority of patients. Be very, very cautious about rushing into an operation with these patients. Some of the options we have are venting gastrostomies, Botox, stimulators, pyloric-directed therapies, and resectional surgery. I would have loved to come up with a little flow chart and an algorithm today. It's not going to happen. I'm on multiple international guideline panels looking at this. Everybody has tried to come up with a lovely flow chart to tell you what to do and when to do it. There's no data. You can try one thing first and another thing second, or the other way around. Surgery should be a long way down the list because these are difficult problems. And that's I guess the big take-home message that I'd like to say, even as a surgeon who does a lot of GPOM, be very careful about rushing into operations on these patients. There is certainly a role, but it doesn't always go as well as you think. Even if you get good resolution of sort of gastric emptying problems, the symptoms sometimes persist. Venting gastrostomies are very good. Often the patients are very familiar with them. When they get pain or issues, they just vent. You can have something beyond the pylorus as well that's helpful for post-pyloric feeding. It's obviously not a great quality of life, but it does get a lot of people out of hospital, and we know that it does work to maintain sort of pain-free life. The recommendations in that Camilleri article in 2013 in the AGJ was that it is useful for symptom relief, but it clearly doesn't definitively treat the disorder. Botox, we've all used Botox. It makes a lot of sense. You think if you're about to do something to the pylorus, similar to the lower esophageal sphincter, if you paralyze it temporarily and reversibly, if it works, it's going to bode well, and if it doesn't work, probably not. 2 large randomized controlled trials show that doesn't work. So both the AGA and the European societies have recommended against the use of Botox. There's 2 large trials, as I said, with no benefit over placebo. ARTS trial in 2007 was a crossover trial injecting saline and botulinum toxin. There was no change in gastric emptying and no change in symptoms. And the same from Friedenberg a little later. Both gastric emptying and clinical improvement really didn't vary. It's still being used as a test beforehand. It still makes sense, but I'm just not sure we have the data to support its ongoing use. GES does work. As you know, it's approved. The mechanism of action is unknown, and what it does not do, it does not reliably improve gastric emptying. And that goes back to the fact that we know that many of these symptoms are related to the gastric emptying anyway, but this certainly doesn't fix gastric emptying. It does improve nausea and vomiting, though, and probably better with diabetics. One paper, an early paper I've provided, shows how the diabetics probably did better than the idiopathic group in terms of both nausea and vomiting, but not the other markers of gastroparesis. There is one randomized controlled trial of about 3 that have been published that showed no initial benefit in weekly vomiting frequency, but probably there was some change at about the 1-year mark. So there is some data to support it, and certainly some people get some very good success with it. You can try temporary pacing beforehand to hopefully increase your outcome risk or percentage. And this guideline, again, many years old now, does support its use as compassionate treatment, particularly in diabetic patients, though it is being used in idiopathic patients as well, with multiple reports of good effect. The studies here are not very good, and this is a major area for research that should be achievable, but hasn't been done yet. Pyloric-directed therapies are the big thing, I think, at the moment. GPOM has very good success rates early on, at least in the meta-analysis. They probably decrease over time, and we know that there are a large number of patients with gastroparesis who have a GPOM and they don't get a clinically significant result. We don't quite know why, but we know this is more about the symptoms than it is about gastric emptying. And even with the sort of the discoordination of the anteroduodenal contractions, simply opening up the pylorus may not improve gastric emptying anyway, but gastric emptying is not the whole thing here. It probably works best on diabetics. There was a randomized controlled trial out of Europe that showed that diabetics had better improvement than some of the others, and there was another retrospective large study from Mexico that showed the same thing. Laparoscopic pyloroplasty is performed widely as well. The results seem to be very good. There's no randomized controlled trials. There's a marked paucity of data here as well. One would think that would probably work in the same way as GPOM, but we don't know. It seems to be quite good, and I use it, and I think the results are reasonable, but it should certainly not be a first choice in essentially an unproven operation. How can we try and work out which of these pyloric-directed therapies are going to work? Is there a way to tell in advance? It's clearly a heterogeneous group, these gastroparesis patients, and maybe there's a group where the pylorus is the problem, and if we targeted those ones, we would get better results. There certainly is some evidence that pyloric distensibility, measured by the EndoFlip device, is inversely correlated with both gastric emptying and the symptoms. And there's some very small cohort studies that suggest that there's a cutoff around about sort of 8 to 10 millimetres mercury distensibility that might provide a favourable response to GPOM. It's got a very low negative predictive value, so you can't really tell who's going to fail GPOM, but it might pick up the people who respond. The data's so small, I don't think we can make any definitive decision on that. But I think that is coming. I think this is one area where we will have data in coming years. Resectional surgery is performed. There's sleeve gastrectomies, which promote gastric emptying, partial gastrectomies, Roux-en-Y reconstructions, total gastrectomies. All of those have been done. They've all got possible side effects, particularly in malnourished patients, particularly in patients with chronic disease. It's a very aggressive step. It should not be the first step. But it probably is more useful in the post-surgical gastroparesis patients who've had bilateral vagotomy at revisional hiatal hernia operation or something like that. Again, not much data, but certainly been performed. So you've seen this flow chart already. What should we do? SAGES is actually coming up with guidelines for the management of gastroparesis under Dr. Richardson's leadership. Hopefully we'll have a little bit more guidance coming up in the near future. But most of it seems to be following the lead of those previous guidelines from the AGA that have been published. Till then, that's what we've got, and you can see down the bottom left, for severe gastroparesis with everything going for it and everything tried beforehand, then sort of as a last-ditch attempt, these things are very good options, and certainly there are patients, like we heard from before, whose life is quite miserable before therapy and much improved afterwards. So we don't want to deny anybody care, but to be very, very cautious about rushing into it. It should be multidisciplinary assessment. As the previous speakers have mentioned, you need everybody involved, and it has to be a well thought out approach to these patients. Thank you.